This video recording is strictly for RCSI educational revision purposes only, and it is not created for external use. It also means these will be sent to you by private links. You are asked to be professional about that and not forward them on to other people, because they are really only meant to be for RCSI staff, okay? Right, so what are we talking about going down through the spinal cord? Yeah, corticospinal tract going from here down. Fine, corticospinal tract. And this one is looking at? Motor, yeah. Okay. What goes up? Spinothalamic tract, yeah. Fine. And what else goes up? Dorsal columns. Okay. So the dorsal columns are going up through here. Yeah. And where the spinothalamic tract's going up through? You have a choice of this or this. Which one is it? Second. This one? Yeah. Everyone happy with that? That's spinothalamic tract. And this one here? Corticospinal tract. Okay, they are the main things we need to think about. All right? So, if someone has weakness, the weakness could come because they have a lesion in the brain. Yeah? They have a lesion in the spinal cord. They have a lesion somewhere coming out from the spinal cord. So what comes out from the spinal cord? Yeah, nerve roots, right? For nerve roots first. And then we call this the root. Then the peripheral nerve. And what else? Then your neuromuscular junction. Very good. There will be no prizes for who did the better drawing today. But you can see how this is so much more helpful. Okay, so leave that one aside for a second, because we're going to talk about weakness in relation to the brain, first of all. If someone has a weakness that's coming from their brain, what other features are they going to get with that? So, if you have weakness and the lesion is in the brain, what part of the brain are we talking about? Generally, it's cortex. Okay, there's a few side rules on that, but you don't even need to go into that. Generally, it's cortex. Okay, so is the weakness going to be on the same side as the lesion or the opposite side of the lesion? Okay, yeah, so it'll be the opposite side of the lesion. So that's one thing that we've got now. So as well as having weakness, it's going to be contralateral to wherever our lesion is, if it's in the brain. What else are we going to have with it? Hypertonic. Okay, we'll probably have increased tone. Why will we have increased tone? Yeah, you're getting at it? Okay, so how do we do an awful lot of our movements on a day-to-day basis? They work through a reflex arc, don't they? So what you have is, see if I have another diagram that I can let you draw on stuff. I might have a reflex arc saved here somewhere, because I am clearly hopeless at this. Lovely. Are you able to draw that reflex arc for us? Coming out from the side there? Great. And you can have this one too if you need an extra colour. Okay, so what do you have happening in a reflex arc? You have a muscle or you have a sensory end organ, don't you? Yeah? They go to where? Back to the spinal cord. And then what happens from the spinal cord? A motor reaction occurs thereafter. So if you were going to do my meter, for example, what happens? You touch the patella tendon, and that's the sensory input, isn't it? Yeah? That sensory input goes back to the spinal cord, and if we were unevolved animals, it would go from the spinal cord to where? Back up to the brain, and then the brain would sense that it needs to cause what? A motor reaction, yeah? But we aren't unevolved, despite what reality TV tells you. So what happens to us instead? I touch the tendon here. That sensory message travels back to the spinal cord, and then the motor tract in the spinal cord picks that up and effects the movement, which is the contraction of the quads. And then you see the knee jerk out, yeah? So that's a normal reflex, yeah? All through a spinal arc. It doesn't bother the brain, okay? And the message only gets to the brain retrospectively. How is the brain involved in it at all? It causes modulation of that reflex arc. So it doesn't mean that every time you touch here, I keep going like that, right? So what happens with the brain is it retrospectively gets all the information and then says, calm down, stop moving through that reflex arc. So it modulates the reflex arc. Why is that important for you to know? Because it's the entire basis of why we get hypertonia in upper motor neuron disease and hypotonia in lower motor neuron disease. So if I have someone who gets a lower motor neuron defect, where's the lower motor neuron? It's coming out from the spine, yeah? It's no higher up than that, yeah? Is everyone happy with that? So that is the neuron that is involved when I touch here. It is the motor neuron that affects the quad movement. That's a lower motor neuron, yeah? So if I get a lesion somewhere along there, what is going to happen? Is this reflex going to be able to happen? No, it's going to be hypotonic, yeah, and areflexic, because we have stopped that motor neuron, which was the only motor input into creating this reflex, yeah? What about if I get a lesion in the brain? Well, how does that affect this reflex arc? The ability to modulate that reflex occurring is gone. So as a result, you get hyperreflexia and hypertonia. Okay? So you need to understand reflex arc to understand why you're getting these features in the first place. Does that make sense to everybody? And it'll make even more sense when we look at Lisa's perfect diagram of it. That looks really symmetrical to me. So, therefore, if we are talking about this person who has weakness and we think it's coming from the brain, we're happy that it's going to be contralateral, and then we're also happy that because they're unable to modulate reflex arcs anymore, they're going to have increased tone and increased reflex. Yeah? Is everyone happy with that concept? Okay. What about muscle loss? Will they get much muscle loss with that? They will get some muscle atrophy, but it's minimal, okay? What about fasciculations? Will they get those? They won't get them, okay? So now you're talking about one pattern of disease that you should be looking for in your OSCE, okay? Whereas if you see weakness, in the context of other problems in the brain, you're not going to get these patterns with them. Okay? So let's say we have someone who gets a lesion around here. What structures could be affecting them there? Yeah, so the nerve root could definitely be involved. Yeah, but the vertebrae won't cause much neurological features, right? It's what the vertebrae compression causes. So you can have some nerve pinching, but again, that comes back to nerve root. What else, though, inside here could be affected? The anterior horn could, couldn't it? Yeah. All right. So let's think about the kind of features you would get then. Are we talking about central nervous system or peripheral nervous system?
Peripheral.
Yeah, peripheral nervous system. So peripheral means what? What are the areas within the peripheral nervous system? Because we're copied central as brain and spinal cord. So what are the ones that are in the peripheral?
Anterior horn cell.
Yeah, the anterior horn cell. The nerve root. The peripheral nerve. The neuromuscular junction. And then you can put a line through this because the end organ may be involved. For example, you can have neuromuscular diseases where both you have peripheral neurological problems and muscular problems as well with the end organ. Okay? So, if we have a weakness and it's coming from somewhere down here, what other features are you going to get with it? Firstly, which side is the weakness going to be on? Yeah. Is everyone clear with that? Why is it ipsilateral? So where's the motor input down here? It's your corticospinal tract, isn't it? And where does the corticospinal tract decussate? Low or high? High, yeah. So this is a brain. It's a brain, okay? This is your medulla. And this is your corticospinal tract. And it does its decussation there. Yeah, very high up, sort of above the spinal cord. So, if we cut down here, somewhere in your spinal cord, you will get ipsilateral weakness. Yeah? Does that make sense to you? Okay, what will happen to the tone and the rigidity? What we're talking about here is this corticospinal tract is the motor element of this reflex arc, yeah? That's what's been damaged. So this is our muscle. Yes, this is our muscle. This is our skin. So this is the sensory. This is the motor. So we touched the skin on the knee at the patella tendon. That's sensory. A message went all the way up here, synapsed here, and caused the motor part of the corticospinal tract to cause a muscle contraction. Yeah? If we have a lesion in that, what is going to happen to that reflex arc? Is the reflex going to happen? No. Is the tone of this muscle therefore going to increase? No. So what will you get? Areflexia and hypotonia. Okay, so in the exam, those are two really key patterns that you should be looking for. Weakness. You will get weakness with both, but then you want to see, is the weakness ipsilateral or contralateral? How do you know if it's ipsilateral or contralateral? If I have weakness all down this side of my body, and I'm holding my arm like this and like that, how do you know if that's ipsilateral or contralateral? What do you need to know about me? You need to know about dominance, don't you? That's the only thing that's going to give you the clue. So you need to know, am I right or left-handed? Yeah? And if I'm right-handed, you would expect that my dominant hemisphere is the left, 90% of the time. And so you would be expecting that an awful lot of my motor control comes from over here, and therefore, if I have abnormalities on this side, it's contralateral to that. Yeah? Not as easy for people who are left-handed. Okay, so two clear patterns there. What about weak sensory abnormalities with those? Do you expect sensory abnormalities with these? It's a plus or minus. They may happen, they may not. So with this pattern, what sensory abnormalities would you expect? Contralateral or ipsilateral? Generally speaking, it will be contralateral. There's a few exceptions, and we may not talk about those today. We may talk about them the next day. But generally, the sensory abnormalities you would expect would also be contralateral. With this, if the lesion is just here on sort of one side of the cord, what kind of sensory abnormalities do you think you might get? The modality, yeah, it depends on the sensory modality. Why does it depend on that? So you have two different tracks here, don't you? You have dorsal columns and spinothalamic. Okay, so we're after making a lesion here, right? So we're saying that something like this is after happening. Some damage from here outwards. Okay, so what kind of sensory abnormalities would you expect with that then? Are your dorsal columns affected? They are, yeah. Are your spinothalamic tracts affected? Yeah, they are. So, will you have ipsilateral or contralateral loss of those? Loss of those sensory modalities. So dorsal column is proprioception and vibration, and its spinothalamic tract is pain and temperature. Yeah. Okay. So if we have a lesion that's somewhere along here, and all of this part is affected outwards, so the anterior horn cell is affected, dorsal columns are affected, spinothalamic tract is affected, the nerves peripherally are affected. What's the sensory problem you're going to find? It'll be like a Brown-Séquard type of picture, won't it? So what happens with a Brown-Séquard picture?
So at that level, they'll have loss of all sensory modalities.
Yes.
They'll have contralateral loss of pain and temperature.
Yes.
Ipsilateral proprioception.
Yes, exactly. So they will lose the dorsal columns ipsilaterally, and they will lose the spinothalamic tract contralaterally. Why is that?
Because the spinothalamic deficits.
So if we're talking about this place here is right here on my drawing, and we have the spinothalamic tract coming down from the brain, and it's coming down from here, it goes here. When does it decussate? Literally as it moves out, yeah? Is everyone happy with that? It only decussates as it moves out of the brain. Whereas with the dorsal column, what happens?
You go off with the midbrain.
Yeah, so it goes all the way up here, and then it crosses over. Yeah. So if you have a lesion here, can you see that it will cause, therefore, ipsilateral loss of dorsal columns, contralateral loss of spinothalamic tract, all because of where the decussation occurs. Okay? So your weakness, which is ipsilateral areflexia and hypotonia, may have a few different sensory abnormalities with it. And the sensory abnormalities that it will have with it will depend on what part of anterior horn cell, peripheral nerve, anterior horn cell, nerve root, peripheral nerve, and neuromuscular junction the lesion is occurring in. Yeah? Some of you look very, very concerned. Are you happy about how the weakness is contralateral here, weakness ipsilateral there? You're okay with me on that? Understand that tone and rigidity will be up in this one because there's no modulation of your reflex arc. Tone and rigidity will be down on this because the reflex arc no longer exists. So it's the sensory problem that's getting you. Is that it? Yes, okay. So maybe if I had a better drawing, it might be easier for you. Not that one. Should be another one here. Seems to have gone missing. Okay, what we can do is, I have it in my laptop, so would you be able to draw it off that for me, Lisa? Great. Pictures. I think that's probably the best one. Or I have also.
Maybe that's better.
Okay.
This is too confusing.
Yeah, that's fine. So just close that one down. And where is it gone again? This one.
Okay, what do you want me to erase?
I'll erase all my stuff over here. Okay, Lisa is going to save us with another fabulous drawing. And while she's doing that, I think everyone was comfortable with the idea of if you have a lesion in your cortex, you will get contralateral weakness. Yeah? What else? Come on, you can say it. Lesion in the cortex, contralateral weakness, plus hypertonia, hyperreflexia, muscle wasting, little bit, not much. Fasciculation, not much. And what you might also have is clonus and Babinski reflexes, so increased reflexes there. So let's talk about then, when you have a pattern like that in your exam, what differential you are going to give. So you're pretty sure that the motor cortex of the brain is involved, yeah? So you need to come up with some organized way of giving the causes of a problem there. So, anyone? Sorry? Yeah, so vascular causes would be the most obvious one. So the vascular ones that we see most commonly are ischemic strokes, but other ones that could be there are hemorrhagic strokes and then intracranial and subdural bleeds. Yeah? So put all that into your vascular differential for this particular pattern of abnormality. So other than vascular then, what would come up there? Sorry? Neurological? No, so all this stuff will be neurological. What's the disease you wanted to give us an okay, so neurodegenerative, right? Or else you can call them inherited, but some of them aren't. So neurodegenerative is the better term to use. So Parkinson's to some extent, but most of it's extrapyramidal, isn't it? What other neurodegenerative ones do you know? We'll stay on the neurodegenerative so we get that list finished, and then we can move on to those ones.
ALS.
Yeah, all motor neuron disease, with the classic one being ALS. Now, ALS is a funny one because you can get quite a lot of spinal disease with it as well. We'll come back to that. Okay, what else, guys? MS, yeah. Generally, you're right that it is neurodegenerative. Usually we put it into the category of immune-mediated or autoimmune. Now, I don't really care what you would say on the day. So just don't be surprised if you see it in a different category. What else would go into the neurodegenerative? We talked about a few of them the other day. So Huntington's could do this, because we know that it causes basal ganglia disease primarily, but it also causes motor cortex disease because they get motor weakness. So they do get all of these features: weakness, hyperreflexia, hypertonicity, minimal muscle wasting, etc. And therefore, there are lots of other neurodegenerative diseases of which you've heard too. And some of them are metabolic based, like mitochondrial diseases, carbohydrate storage diseases, things like that. Certainly you're not expected to know much about those, but you should have them as differentials. So we've done vascular and we've done neurodegenerative. Yeah. Alzheimer's goes into neurodegenerative as well, yeah. And can they get motor abnormalities? If they can. It's not an early thing, but they can. And actually what you often see is people who have vascular dementia. So they have Alzheimer's type cognitive impairment, and then they have all these motor features that you would get like with a stroke. So we would put those into the neurodegenerative as well. Okay, so we've 2 categories done, all of which could give us that pattern. So you're doing really well in your OSCE if you're after coming up with all of that stuff. What else? I didn't hear one unifying thing there.
Neoplastic.
Yeah, neoplastic. So any either malignant or benign tumour that takes up space in your motor cortex, plus any metastatic disease. All right. Okay, so other than tumours, infections. So which infections? Abscess and TB. Yeah. What type of TB? So you'd want it to be a TB abscess or TB meningitis encephalitis, right? Now, in reality, we catch meningitis very early these days, so the majority of them have not gone on to have significant damage to their motor cortex, so it's not commonly seen there. With the encephalitis ones, their neurological symptoms tend to be what? Yeah, change in behavior, irritability, personality change, plus or minus localizing neurology like a cranial nerve palsy, for example. And which cranial nerve palsy do you think is the most likely? 6, yeah, why 6? Longest intracranial route, so if you have inflammation of the brain, it's the most likely to get pinched by that, isn't it? Yeah, good. So encephalitis and meningitis theoretically can cause significant damage to your motor cortex, but in reality we usually catch them much earlier than that happens. In the developing world it would be a different story. So the infection that is more likely to cause problems is an abscess. Yeah? And what kind of abscesses do you get? So it could be a TB abscess, could be abscess related to HIV infection, could be helminthic. Yeah, you could have an ascending infection from your respiratory tract or your ears that could have caused an abscess too. All right, so we're happy we've got the vascular causes, the neurodegenerative causes, the tumor-related causes, and space-occupying lesions, including abscesses. What other space-occupying lesions do we need to think about besides tumors and abscess? Yeah, aneurysms and AVMs. So aneurysms and arteriovenous malformations. Okay. Right.
What about the rare amyloid prion
yes, amyloid, prion disease, all that kind of stuff can do it. HIV, leukoencephalopathy could do it because they don't have great preferences for particular parts of the brain, so they can turn up anywhere. So anything like that could do it. Then as a result, also you need to think about toxins that can do it. So amphetamines, carbon monoxide, cocaine, all can cause significant damage within the motor cortex. Some of them it's due to direct toxicity of the drug, and some of it is due to them causing vasospasm. So they actually cause a vasculitic type process. Okay. But all of those things would be the smaller print. Great if you're able to remember them under the day, but certainly don't say those things first. Say the things that we've mentioned up until now first. Okay? Any other category that you would talk about there? Autoimmune, right. So could autoimmune disease cause you to have a motor pattern like we just talked about, weakness, hyperreflexia, hypertonicity, etc.? Could, right. So, yeah, lupus vasculitis, microscopic polyangiitis, they all will be causing mini stroke type pictures. So absolutely they can do that. And then the other big immune-related disease is multiple sclerosis. So could multiple sclerosis cause that? It absolutely could, right? If it is multiple sclerosis, what would you expect besides all of those features? Yeah, so eye problems. What you're looking for is that weakness, that hypertonicity, hyperreflexia, etc. We can define where in the brain they're all coming from, can't we? It's the motor cortex, yeah. What are you looking for in MS? Yeah, but even so, they could get those features relapsing remitting. But what you're looking for are two lesions disseminated in space, okay? So they have all of those features, and then they have some other features that aren't explained by motor cortex disease, that are explained by a lesion somewhere else in the brain. So optic neuritis would be enough. A sensory paresthesia would be enough. A cerebellar features would be enough. That's what you're looking for in MS. Two separate sets of clinical features that do not relate to the same anatomical area in the brain. That's what we talk about lesions disseminated in time and space. Okay? How are you doing? I think once we have spinothalamic and dorsal columns. So what have you got so far? Yeah, great. Okay, kids, you keep going for a minute. Yeah, and just label them then when you're done, please. Thanks, Lisa. Okay, so now are you happy that if you have someone in the OSCE and they have 1 to 5 of those clinical features that we talked about there, that you have a decent differential for it? Yeah, and you're happy that all of that stuff is coming from the brain? Yeah? Okay. Pretty much all of those disease processes that we just mentioned as causes can also occur in the spine, can't they? You can have spinal infarction, you can have spinal bleeds. Yeah? You can have a tumor in the spine, you can have an abscess in the spine. You can have infection of the spine causing myelitis. Yeah? Any of the drugs that work to cause problems in the brain will also cause problems in the spine. Okay? So, you need to think about the fact that that differential can be applied to a different set of features too. Because if you have spinal cord syndromes, the clinical features might be slightly different, but they are coming from the same process. So let's talk about a few different spinal cord syndromes while Lisa's finishing that up. Let's talk about anterior cord syndrome. So anterior cord syndrome means what? You knock off which parts of this? Is the dorsal part the anterior part or the back? That's the back, right? So this is the posterior part, this is the anterior part, yeah? Okay, so if we say someone has an anterior cord syndrome, we are saying they have a tumor in the cord. They have an infarct to one of the vessels supplying the cord, yeah? They have an infection that's affecting this particular level of the spinal cord, yeah? Any of those diseases that we said could affect the brain, one of them is occurring here, but it's only occurring in the anterior part, so this part only, okay? And how deep is it? We don't know. It could be going from L1 to L5, it could be going from C1 to C5, it could be going from C8 to T1, okay? So if you have one of those disease processes occurring across the front part of your spinal cord, and it goes a few levels down. So for our example, let's say it's at C8 to T1, okay? That's the level we're talking about. What features are you going to have then? From a motor point of view, what features are you going to have then? Are we talking about central nervous system findings or peripheral nervous system findings? Yeah. So is everyone clear that once we get into the spinal cord here, we have an anterior horn cell, and that anterior horn cell gives you a peripheral root, and then that becomes a nerve, yeah? So that's the stuff that you are damaging here. You're damaging the anterior horn cell, the nerve roots, and the peripheral nerve, yeah? So you're going to get weakness, aren't you? And you're going to get hyporeflexia and hypotonicity for the reason we talked about with this reflex arc, yeah? What else will you get? So anterior horn only, so we're only down from down here. So what parts of your pain are affected? Are your dorsal column affected? No, they're fine. So only your spine and thalamic tracts are affected, okay? So you're going to have pain and temperature loss. We're saying that this lesion is all the way across here. So are we happy that this patient who has C8 to T1 involved, from C8 to T1 on both sides of their body, they are going to have hypertonia, hyperreflexia, weakness, and they are also going to have sensory loss, yeah? And we call that a sensory level, yeah? Because you'll be able to see when you examine this person, they're only missing C8 to T1. So if you put them in a dermatomal position and you test their dermatomes, what will be absent? Somewhere down around there, right? Okay. Yeah, and so C1, C2, C3, C4, C5, C6, C7, C8. They'll be missing what? C8 here, and then T1 across here, T2 across here, yeah? And so you will have them there trying to examine them, and you will be doing pinprick with them, and you'll say, can you feel this? And they'll say yes. And then you'll go through here, and they'll say yes, 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 and then they come to here, and they say no, and they come across here, and they say no, and they come across here, and they say no, and that's a sensory level, yeah? So if you have an anterior cord syndrome, bilateral lower motor neuron lesion findings below the level, and bilateral sensory loss below the level, yeah? Is everyone okay with that? That's not difficult, guys. That's easy, but you have to understand where stuff is in the cord for you to get that. Do you need me to say any of that again? No. Okay, let's imagine.
The syndrome will affect both.
We're saying that the disease process that is going on is either a tumor or a bleed or something that has affected from C8 to T1 from the front downwards, okay? So the front part of your spinal cord from C8 to T1 has a tumor in it, or has an AVM in it, or the artery supplying those three columns has bled or has stroked or something like that, yeah? So that's your anterior cord syndrome, okay? All the same pathologies that occur in the brain But the findings you are going to get are lower motor neuron findings from a motor perspective and bilateral sensory loss, pain and temperature. Yeah? Okay? What if I were to say that the lesion was somewhere in here, that someone was getting spinal stenosis, for example, or they had a tumour growing up through the middle? So they have central cord disease. So all of this is what's being affected. What kind of symptoms are they going to present with primarily? Yeah, so they will get some dorsal column and they'll get some spinothalamic tract. Which do you think gets affected first? The compression tends to push out this way first before it starts pushing up that way, okay? So they get loss of their spinothalamic tracts first. In your spinothalamic tracts, you have somatotropic distribution. What does that mean? You totally get this when you're in neuroanatomy.
Within the tract, there are areas that represent different parts of the body.
Yeah, very good. So in this tract, the most inner part of that tract represents the cervical sensory area. The next part is the thoracic sensory area. The next is the lumbar. The next is the sciatic, right? Why does that matter? Can you imagine if you have some tumor or aneurysm or abscess pushing here, what area is it going to affect first then? Your sensation in your cervical region, followed by your sensation in your thoracic region, yeah? And does that explain to you why when people have a central cord syndrome, they get a shawl-like distribution of their sensory loss? Because it moves outwards from their cervical, thoracic, lumbar, okay? The second thing you need to think about is that these corticospinal tracts also do that. That's a somatotopic distribution. So how do they do it? They do it upper limbs inside, lower limbs outside. So if you have a central cord lesion, you are going to definitely get sensory abnormalities first in your cervical thoracic area. And where are you going to go first get motor abnormalities? In your upper limbs and thorax, yeah. Okay? And what will those sensory abnormalities be? Most likely spinothalamic tract, because that gets crushed first. So pain and temperature loss. Bilaterally, because this is a circular lesion that's pushing outwards, so it's affecting both sides. And then eventually you'll also get some dorsal column loss. Yeah? What kind of motor findings will you get with it? Are we talking about upper motor neurons or lower motor neurons now? Lower motor neurons, yeah. So you're going to get weakness, hyporeflexia, hypotonicity, muscle wasting, fasciculation, etc. bilaterally. Okay?
Sorry, I don't understand why it's going to be a peripheral nervous system down.
So once the spinal cord has given the muscle has given its nerve into the anterior horn cell, from then on, it's all peripheral nervous system. So at this level, when it's coming out here, it's going to be a peripheral nerve, okay? Because it's giving, before the anterior horn cell, it was an upper motor neuron. At the anterior horn cell, it becomes a lower motor neuron.
But the stenosis will be affecting the spinal tract, right?
Yeah.
Which is a central part of the central.
But it will be affecting at each level here. And it's at each level that it moves out. So, yes, this is all part of the central nervous system, right? But it's affecting it at this level where you move out. And when it moves out, it becomes the lower motor neuron. Does that make sense to you now? Kind of. You have to look at it again in your neuroanatomy and it'll be very clear to you then, okay? All right, so that's an anterior cord syndrome. So any of those things that we said that could happen in the brain, the vascular, the infections, the neurodegenerative, the AVMs, the tumours, all of that. If any of those occurred in this part, you're happy you'd know what kind of findings you'd be expecting. Yeah? If those happened in the middle here and they pushed everything out, you know that they're going to push downwards first, and the spinothalamic tracts will get affected first. Then the corticospinal tracts will get affected, and then finally the dorsal columns will get affected. And because it's in a somatotopic distribution, we know that the first places to get affected would be the cervical distribution, sensory-wise, and the upper limbs distribution, motor-wise. Yeah? Are we okay on that? I know this isn't easy, so we can go back over it again next week once you've had time to read through it and you have more questions. But if you try and get the basic concepts in, it'll make it so much easier when we're actually going through the different neurological diseases.
So just due to the stenosis there, I'm not going to have an upper motor neuron lesion at all.
You might have an upper motor neuron lesion just at the level, right? I was trying not to complicate it with that today, but you can get an upper motor neuron lesion just at the level, and below the level in the three other areas affected. So if we're saying C8 to T1 is affected, at C8 you might get an upper motor neuron lesion because you're in that anterior horn cell. In the anterior horn cell you have the upper motor neuron meeting the lower motor neuron, and if the anterior horn cell is affected here, both are going to be affected. So the lower motor neuron going for C8 downwards will cause lower motor neuron findings between C8 to T1 then, but at the level of C8 you might have an upper motor neuron lesion. That's kind of semantics, because if you have an upper motor neuron lesion only at C8, what findings are you going to have? Is that patient going to get weak with just C8 upper motor neuron lesion? No. They're going to lose a reflex. What reflex is C8 involved in? Yeah, but it's not an isolated one, is it? So 6, 7, and 8 can be involved. So are they going to lose their reflex? No. So it's nice to know from a neurological point of view that they have the upper motor neuron lesion at the level, but functionally in real life they get no clinical features from it because it's only one area that's involved. Whereas if you have all of C8 to T1 with lower motor neuron lesions and sensory abnormalities, that will definitely give you features, won't it? Yeah? Everyone happy with that? Yeah, okay. All right. So let's talk then about what we were talking about with the Brown's card now, because Lisa has given us a lovely diagram. It's going to be so much easier. So what does Brown's card mean, really? What's the easier way of terming it? It's hemisection, yeah. So we talked about transection earlier on when we were talking about only the anterior areas being involved, yeah? But now hemisection, we're talking about a line down here. And actually that line might be a little bit over to here, or it might be a little bit over to here, or it might be a little bit incomplete and not go all the way down, okay? It is really, really uncommon for someone to have a pure hemisection, okay? The person who is murdering them wants to really know what they're doing if they manage to get a pure hemisection. So the vast majority of people who have a hemisection, it's related to trauma, right? And usually it's not that symmetrical. But let's theoretically imagine we have a perfect hemisection for a moment, okay? So all of this is lost, right? Everything on this side is dead because it has lost its blood supply, or there has been a stroke in its blood supply, or there's an infection in it, or there's a tumor eroding through it, or there's a degenerative neurological disease that happens to be hitting a few places between C8 and T1, because they're going to be our example for today. So any of those disease processes we talked about, okay? The most common is hemisection, but we have to think about all those other things that could potentially cause the equivalent of a hemisection by just causing damage to one side. So we have here now loss of spinal tract. Everything's happy. That's gone. Yeah? Corticospinal tract. That's gone. Yeah? And dorsal columns are gone. Okay? And this is the person's right side. This is the person's left side. Or is that how you drew it? Did you draw it the other way around?
I just drew, I'm not sure, I just drew how the picture was.
Okay, we'll be able to figure it out either way. So, where is our dorsal column? Great. So this is our dorsal column here. Dorsal column going up or going down? Yeah, so it starts at the skin or the sensory organ and it moves upwards. Yeah. So let's say it has come from, is this it joining here, Lisa? Is it meant to join here?
Yeah.
Out to here?
Yep.
No, that's fine, grand. So this is the sensory part of the dorsal column in the foot, and it's going to manage your vibration and proprioception, so you are able to do what? If you're walking downstairs, you know you need to change your gait. If you're walking on an uneven surface because you're hiking, you are able to sense vibration and proprioception in your feet, and you're able to change your joint position in space. Okay, so it's in your foot and you're waiting to do something with it. Okay, so it goes all the way up here, all on this side, all on this side, all on this side, and then when it gets to the medulla, it crosses over. Yeah? The kind of lesion we're talking about here, where is that kind of lesion happening in this diagram? Is it happening up here? No. Is it happening here? No. It's happening here in the spinal cord. Everyone happy with that? Yeah. Okay. So let's say this gets cut here then, because all this side is gone. Yeah? Through this heavy section. Where are you going to lose the dorsal column sensation? On this side or on that side? Hands up who thinks it's this side. Hands up who thinks it's this side. Okay. So you've lost it from here, right? And that message is coming from down here, isn't it? So it's going to be ipsilateral. Does that make sense to you? The message is coming from here. I've got a break in the message here. So that's all on the same side. So the sensory loss that I get with that is going to be on that side. Yeah? Is there anyone who doesn't get that? Okay, so I have a sensory message sent from my foot, and it is trying to reach up here in my brain. The way it does that is it goes through my spinal column on the same side as my foot. So we're going to say this is the left foot. It's on the left side of the spinal column. It's in the left side of the medulla, and then it moves over to the right side of the medulla and over to the right hemisphere. Okay? But where the lesion has now occurred, because we're talking about a hemisection of the spinal cord, we're not talking about a lesion occurring in the brain. We're saying that damage occurred at somewhere here, and it broke this area of the spinal cord, and everything on this side of the spinal cord is now lost. Okay? So that message that was trying to travel up ipsilaterally on this side can't get up there. So I've lost it ipsilaterally. Does that make sense? So everyone clear now why, if you have a hemisection, it's ipsilateral dorsal column loss. Yeah? Let's talk about the spinothalamic tract then. So where do we have that start? We have it here, and it goes down here, and it has gone over to give temperature to this foot. Excellent. So, again, our message is starting down here, isn't it? We want to know if this foot is cold or hot or not. But we've had transection of our spinal cord. And where have we had that transection? Is it down here, or is it up here? In the spinal cord, yeah. So the message is going to get broken where? The message is going to get broken in this part, isn't it? And so where is the message at that point? Is it on the same side of the foot, or is it on the other side? What has happened to the spinothalamic tract? Has it moved to the other side yet? It moves all the way down here. As soon as it relieves the spinal cord, it moves from the other side. Okay? So if we break the spinal cord here, that message has already moved over to the other side. Okay? So what we're cutting off here is a message that is already traveling in the contralateral side of the brain. So doesn't it make sense then that when we have made a lesion here, it is going to lead to contralateral pain and temperature loss? Is everyone happy with that? Anyone need me to do that again? Some of you are like, dear God, no. We have to move on. Okay. Does anyone at the peripherals have questions on that? Okay, so those are 3 important spinal syndromes that you should be able to determine on physical exam now. So let me go through them. I have come into the OSCE and I am demonstrating weakness, and the weakness is in my arms, and it is more so in my shoulder girdle and the tops of my arms than it is in my hands, right? So there's definite weakness there. It's bilateral and it's much worse. I have power of 2 out of 10, out of 4, 1 out of 4. It's not out of 4, it's out of 5. I'm just making up numbers now. 2 out of 5 and 1 out of 5 in my shoulder girdle when you do these movements on me, right? And then in my hands, I'm probably still at 3 or 4 out of 5. Okay, so that's the motor problem that I've got. Weakness, worse in the shoulder girdle than it is in the fingers, okay? Tone-wise, I have decreased tone. Reflexes-wise, I have decreased reflexes. Sensation-wise, I have some loss of sensation, okay? When you do pain and temperature, it seems to be more obvious than in dorsal columns. And the pain and temperature loss is worse in my cervical and thoracic regions than it is in my lumbosacral regions. What do I have? A central cord syndrome. Is everyone clear on that? So the reason why that's central cord syndrome is because there are bilateral findings, which you usually get with the central cord. Because we know the spinal thalamic tract is at the front, it gets crushed first. And it gets crushed in the order of cervical first, then thoracic, then lumbar, then sacral. So you're expecting me to have more cervical thoracic weakness than I will have, or sorry, cervical thoracic sensory loss more so than lumbosacral loss. Then you know the next thing that gets crushed is the corticospinal tract, and the more medial part of the corticospinal tract is the upper limbs rather than the lower limbs, and actually the upper parts of the upper limbs more so than the lower parts of the lower limbs. And you know that the dorsal columns can get affected, but they're going to get affected a bit later. We'll go through that now. So just for 1 second, that was central cord syndrome, and then you'd be expected to come up with diagnoses for central cord syndrome. So what would they be? Spinal stenosis would be a good one, yeah? Syringomyelia would be a good one, yeah? So syringomyelia means what? There's a syrinx, which is like a large bulbous cyst sitting in the middle of the cord. Cervical stenosis, as the name would suggest, the spine is becoming narrower, so it's crushing everything inside it. What else? Infections like transverse myelitis would be enough to do it, okay? An abscess at certain areas, yeah? What else? What about vascular stuff? What about an infarction? Yeah. What about a tumor? Sitting in the middle, pushing everything else out, okay? So it's not that hard. It's all the same stuff that would be in the brain, but it's just in the spinal cord. Let's talk about then if I had weakness, because everyone will have weakness, right? And with the weakness, I have predominantly sensory abnormality, which is anesthesia or paresthesia, okay? When you test my pain and temperature, they're a problem, okay? And they're more gone in the cervical area than they are in the thoracic area than they are in the lumbar area. Okay? And I have completely normal dorsal columns. Normal sensation to vibration, normal sensation to proprioception. And with my weakness, I also have hypotonia, hyporeflexia. So that would be an anterior cord syndrome. Do people get that?
So you still have the somatotropic distribution.
Sorry?
You still have
The somatotropic distribution, you'll always going to have that. Like that, it isn't that this changes further down in the cord or anything like that. Okay, then what about if I have weakness, and my weakness is on my right-hand side? And it seems to be that I have it from the level of C6 to T2, roughly. Okay, so on the right-hand side, I can't do what I should be able to do with C6 to T2. So what should I be able to do with those? Yeah. What muscles are we innervating? Forearm and the hand, right? So it's from here downwards, really, that you're going to find weakness, yeah? So my shoulder is actually okay, but from C6 to T1, I have forearm abnormalities. So this movement and this movement are difficult. All the movements of the small muscles of the hand are low. The power is low, yeah? Reflexes-wise, they're gone, okay? Yeah, I have weakness. Looks like I have some muscle atrophy because I've had this for 6 months. Yeah. In association with that, when you do my dermatomes, you find that I have pain and temperature loss also from C6 to T1 on the same side. No, on the other side, on the other side, on the other side. And when you do vibration sense and proprioception at my fingers, you find that they're gone in the same side. So what do I have there? Hemisection on what side? Right-sided hemisection. And so a right Brown's cord, and it's from where? C6 to T1. Yeah. Okay. Are those beginning to make sense for you? You kind of need to go away and play with these diagrams a little bit and make up a few different areas. So like you might say, what about if we say that there's a spinal cord lesion and it's from L1 to L5 and it's only anterior? What features do I expect to get then? And then do another one, I think it's a hemisection and it's from T12 till L2. What would it be then? So go away and give yourselves a few different ones like that, and it'll really get you good at finding the lesions. And finding the lesions is 80% of the battle in neurology. Now, we really only tackled brain and spinal cord today. There are other areas that we need to talk about, like peripheral nerves, okay? And we will go into that in a lot more detail. And the ones that we will do in detail will be the the radial, the ulnar, and the median, and then the sciatic, the femoral, lateral cutaneous, because those tend to be the ones that are examinable that patients have, okay? Common perineal and lateral cutaneous. Okay, so we will do that probably in the next day. The other thing we need to do is look specifically at other things within the anterior horn cell, because we kind of addressed the anterior horn cell today, but we didn't talk about the anterior horn cell syndromes. And from your point of view, there are only 2 major anterior horn cell syndromes. What are they? Polio and motor neuron disease, yeah, which mainly ALS. And then we also need to talk about neuromuscular junction disease as well, okay? So today was meant to be more about central nervous system, trying to identify the different patterns and being able to identify the lesion and explain why the lesion is what it is. So try and spend a bit of time going over that in the next week, because next week when we do all the peripheral stuff, I want that stuff to be clear to you first, because otherwise it becomes a world of confusion. All right. Can I ask that someone would take some pictures of Lisa's really great drawings so that they can be sent to those who are at the peripheral sites? Because I doubt they're able to see them as well as they need to be able to see them on the camera. You're going to do it for us. What's your name? Marina. It's an excellent name. Doesn't sound anything like mine. Okay, and can someone please give the notes to Lisa, because she had to spend all the time doing pictures, and she did a great job of it.